This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
The numbers needed to treat in primary prevention is in around 40 or less. That's quite a significant benefit in terms of reducing the chances of something that could cause death or significant morbidity in the future. So I think there's no doubt about it that our current obsession with managing LDL and getting it to target comes with significant benefits.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. The European Society of Cardiology recently published a focused update of the 2019 guidelines for the management of dyslipidemias, and this presented an opportunity to review the importance of appropriate management as well as newer tests and management options. And to help me today, I'm joined by two experts. Here they are.
So Eamonn O'Shea is my name. I work as a GP in Galway City and I am the cardiovascular lead with the Irish College of GPs.
I'm David McConaghy, a GP in Sallins, County Kildare, and I'm Irish College of GPs Prevention Lead.
In today's comprehensive review of lipid management in primary care, David and Eamonn discussed topics such as the positive impact of managing elevated lipids on cardiovascular risk, focusing on LDL cholesterol targets for different risk groups, the initiation of lipid-lowering therapy and management of side effects, including considerations for women of childbearing age, the opportunity presented by the HSE GP, OCF, APP and CDM programmes to review LDL levels and ensure therapy is optimised to reach target based on risk stratification, as well as newer developments, including how and when to initiate bempedoic acid, the role of integrated care hubs, and the emerging measurement of lipoprotein A as an independent risk factor. As usual, you'll find links to resources mentioned during our conversation, along with chapter markers and a transcript of the episode in the show notes. Eamonn began by explaining how to stratify patients into risk categories to ensure management reaches the appropriate LDL target.
Okay, so if we start from high to low, we're all probably aware of people that are it is a case of secondary prevention, so they've already had an event, unfortunately, and the European Society of Cardiology would advise that their LDL of that patient should be less than 1.4. But included in that very high risk group, included with the secondary prevention people, would be people with chronic kidney disease with an EGFR under 30, patients with type 1 diabetes over the age of 40, patients with type 2 diabetes who have moderate CKD, so an EGFR of under 45, any case with proven familial hypercholesterolemia, and anybody with a Q risk 3 of over 30%. So those are all people who we should be really trying to aggressively control their LDL to under 1.4. The next group is the group who are considered to be at high risk. So that is people with a Q risk 3 of between 15 and 29%, people with CKD stage 3A, so that's with an EGFR of 45, type 2 diabetes but without target organ damage, and that group of people have a risk of a target LDL of 1.8 or less. And lastly, then you've got your moderate risk group, which I suppose includes most of the people we're looking after, is that their LDL target is 2.6 or less. And that is your people with a Q risk of between 5 and 14%. So that's the way I look at it. I think of 1.4 for the very high risk, including people who've already got disease, 1.8 for people who are high risk, and then the moderate risk group is 2.6.
And I guess, given the fact that, for some of those cohorts in the higher risk groups, many of those are going to be captured at some point in a GP CDM review.
Mm-hmm. Absolutely. And I think one of the things I've often talked to colleagues at work about is that, we see these people on a very regular basis, and I think people need to consider the LDL, and when they're looking at the LDL result on the CDM patient in front of them, just double check, where do they stand in those bands? Is this somebody who's already had an event, so therefore we're really looking for a sharp control under 1.4? Are they people maybe who haven't had an event but have a Q risk that's relatively high? So between 15 and 29%, we should be looking for 1.8 with them, and anybody else then it's 2.6. So think of those targets when you're looking at your CDM patient. I have that chart that has come from the ESC on my desktop, and I consult it on a regular basis.
Okay, that's going to be useful for my own practice, I must say. So thanks for that. So David, taking Eamonn's starting point, I've got a patient and I've set my target, whether that's 1.4, 1.8 or 2.6. Could you walk me through how you go about starting patients when you review them, and what to do when things are going wrong in terms of side effects?
Sure. So when you make a decision that we're going to initiate lipid-lowering therapy, the first thing is to explain to the patient the rationale behind it. So I would explain to them that, you're at increased risk. We're doing something positive now to stop something negative happening. I explain to them, usually it's statins we start first line, and I explain to them how the medication works, when you take it, and then patients often have some preconceived thoughts on statins. They may have read that they cause muscle aches. They're worried about them causing diabetes, dementia as well. And so we sort of discuss that through. The figures on muscle aches are that 1 in 200 people will get muscle ache from a statin. So that means that 199 of those 200 won't. I often ask them, do they have muscle aches to start? Many people in midlife and beyond, and sometimes younger, already have some aches, and I explain to them that if it's down to the statin, you'll be unlucky for it to happen, and it'll be a worsening of where you are at baseline as well. And then we make sort of the decision then to prescribe for primary prevention. Atorvastatin 20 milligrams or rosuvastatin 10 milligrams are a good place to start. 1 tablet a day, and then we will schedule them to come back then for recheck lipids, liver function, and a CPK after about 12 weeks would be the recommendations then. At that stage, if they weren't below target, you increase up the statin. And you might well be also at that stage asking them, are they experiencing any side effects? The muscle aches being the one, or you might find that their CPK has gone very high with the muscle aches, or their liver function is quite off. You may have to modify then. But to be honest, in my day-to-day practice, it's very unusual for me to have to stop a statin on a patient because of liver function changes or muscle aches. It's the exception rather than the rule.
So David, if somebody is not tolerating the statin that you commenced them on, and you're thinking about stopping, are there any alternative strategies before you pivot towards something like ezetimibe?
So some of our patients will not tolerate the statin. Your choices then are that you move to a different statin. So if they were on rosuvastatin, try atorvastatin. I often find that if one of these isn't tolerated, the other sometimes is. Another strategy is to start at with 2 days a week statin. So perhaps start them off Monday and Friday for a few weeks, then up to Monday, Wednesday, Friday, and then virtually over the period of 4 to 6 weeks, build them back up to 7 days of statin. And often this works as a strategy as well. Sometimes a lower potency statin, such as simvastatin, will be better tolerated. In the same way with hypertension, there are some of our patients who might not reach their target systolic blood pressure. There may be some of our patients who do not reach their target LDL. And the important take home here is that some statin is better than no statin. And then also the bempedoic acid and ezetimibe are two others that you might consider using as well in these cases.
Thanks, David. Eamonn, out of interest, would you ever set reminders or anything like that on patient charts where you've recognised that somebody's high risk or very high risk, so that if somebody else is opening it and they don't realise that they're diabetic with, end organ consequences, are there any quick tips like that can align a practice to make sure this stuff is monitored on an ongoing basis?
Yeah, if my colleagues in practice who might be listening to this podcast would start laughing at this point, because you can get a degree of reminder fatigue sometimes. I went stone mad on reminders for a while, and I'm actually cutting back a little bit. Yes, it's useful. I think the CDM program obviously is a key one. I think that's where I'm sharpening up when I'm seeing a CDM patient or an annual preventive program patient. I'm looking at my little reminder on the desktop. What LDL should this patient be at? And I'm thinking of it that way. I do think that you've touched on a point that there are people, the younger group, who are asking to get their cholesterol checked. Generally speaking, I suppose we wouldn't have encouraged that generally, but if there is a family history of premature heart disease in the family, or a family history of high lipids, so they might come to you and say, actually, my brother or my sister has had it checked, and they're told their lipids were high, then I think it is worthwhile checking it in somebody under 40.
And there's a separate podcast on familial hypercholesterolemia, but very briefly, if there is a significant family history, our exam findings are indeed a strikingly high cholesterol result, that would be time to pull up the Dutch criteria score for familial hypercholesterolemia. But we won't go into that too much detail today because there's a separate podcast on that. But
sure,
Eamonn, if somebody has, as David said, they've been titrated, but you're not getting to target with your statin, and you're looking towards ezetimibe and bempedoic acid, maybe you could tell me what kind of a difference they make, and particularly for bempedoic acid, which I think might be a bit less familiar to some GPs, how to go about prescribing that, please.
Yeah, so it is relatively new, and I suppose more and more we are coming across patients who either can't tolerate statins or in whom we're struggling to get to target with the kind of higher doses of the high intensity statins. So if you put it into perspective, and this again is from the recent update of the European Society of Cardiology guidelines, updated this year. So your high intensity statin, so that's your atorvastatin or rosuvastatin at a relatively high dose, that'll get your LDL down to about half of what it was. So it'll get it down to by about 50%. Ezetimibe on its own will get it down a further 20%. And the bempedoic acid is a little bit more than that. It'll get it down by 23%. If let's say somebody can't tolerate a statin at all, if you manage to get them on ezetimibe and bempedoic acid together, that'll bring it down to about 38%. So it's not far off the 50% that we've been kind of trying to get done with the high intensity statin. So they're good agents. They're very well tolerated, it seems, although the bempedoic acid certainly is relatively new. One of the problems, I guess, with bempedoic acid is that at the moment we're limited in that there has to be an application done to the PCRS to get it funded. And a lot of GPs might feel that is something that they'd prefer referred to cardiology to get done, albeit it can be done online through the PCRS. And what they'll want is they'll want proof that the person, first of all, has had a reasonably high dose of a statin, and that their LDL hasn't come down with that, or that they haven't tolerated it. So they'll usually want proof of the LDL level, both 3 months ago when you maybe tried to put them on a higher dose statin, and now.
In terms of the ezetimibe and the bempedoic acid, is there anything in particular that I should tell my patients to look out for in terms of side effects if I do manage to go through PCRS for the bempedoic acid, or if I'm starting on ezetimibe?
They tend to be reasonably well tolerated. Bempedoic acid, if you look it up, it will mention an effect on increasing blood pressure and increasing thirst and appetite and a loss of appetite, nausea. But it tends to, from limited enough experience, I'd have to admit that they're reasonably well tolerated. And ezetimibe, the same. I certainly in practice haven't come across people complaining of much from use of it. So certainly if you compare it to the amount of people that complain of side effects related to the statins, both seem to be pretty clean from that point of view.
And forgive my ignorance, because again, I wouldn't have much experience with bempedoic acid. Do you know, is it a medication that you start low and titrate, or is it a single dose?
No, one dose, yeah.
Okay. David, Eamonn briefly mentioned the idea that if your statin and your ezetimibe is not getting you to target, some GPs may elect to make that application for the bempedoic acid, and others might decide that's the time for cardiology input, which might be a good time to mention the ongoing rollout of the cardiology integrated hubs.
Yeah, we're very fortunate nationally that there's been considerable investment in these integrated care hubs, which should be there in every CHO area. Not all of them are up and running at the moment, but in many parts of the country, you'll find that there is a cardiology hub available to you or if not, it's cardiology outpatients in your local hospital. I think as well as it's worth pointing out that LDL lipids, they're all one part of the whole overall cardiovascular risk, and that often these patients may well have, pre-diabetes, hypertension, as well, the family history. And sometimes when I find that, I've taken the statin as high as it can be tolerated, I've added in ezetimibe or the other agents, and we're not getting to the LDL targets that we wish. Once we've confirmed compliance as well, it's very important. Tablets won't work in the box. They have to be taken. And at that stage, I'll often refer to secondary care for an overall sort of cardiovascular workup as well. And I think the plan is that we will have in the coming 12 to 18 months a lipid service in integrated care hubs nationally as well. When you compare us to our international peers, Northern Ireland, NHS Scotland, we have fewer lipid specialists in secondary care per capita, but this is being addressed, I'm glad to say.
Thinking about all things cardiology, Eamonn, one of the newer aspects of lipid management that I hear from time to time revolve around lipoprotein A, both from at people on the street wondering why I'm not measuring their lipoprotein A at very frequent intervals. Could you maybe parse that one out for me a little bit?
So, yes, I think it's definitely something we'll be hearing more about in the future. It's a very interesting thing. It seems to be something that increases your risk of cardiovascular disease. It seems to be quite independent of the other lipids, so it's independent of LDL. Interestingly, it stays stable throughout your life, so it's not something that you will need when it does become available to us on a regular basis. It's not something that that there's any point in repeating throughout your life. Once in your lifetime, will give you your Lp(a) result, and you don't need to repeat it again. I think there's some debate as to perhaps women after the menopause might need to get a second one if they had one done before then. But so it also isn't modified by lifestyle. And what we know is that it independently increases your risk of cardiovascular disease. So, as I said, labs at the moment do not have the facility to provide it on a regular basis. Some labs are starting to offer it in limited cases. The kind of person you might be thinking about, two particularly would come to mind. One is a person who has a family history of premature heart disease. And particularly in that case if the person has high lipid levels. Because if you think about it, we use Q-risk or we use the score, and very often a young person, even if they've quite high lipid levels, their overall risk will be, in the case of Q-risk, will be under 10%. So we probably won't be advising a statin. But where Lp(a) comes in is that in that situation, let's say you've got somebody with a high LDL, but their overall Q-risk is low because of their age, their relatively young age. If they happen to have an Lp(a) checked and it was high, that might re-stratify their risk, and that might push them into statin territory earlier than would otherwise be the case. So I think it's something that we're going to hear a little bit more about it. At the moment, there isn't any proven therapy out there for lowering lipoprotein A, but those of us that are keeping an eye on the journals will see that there's research coming out. I think those kind of drugs are in the pipeline. So at the moment, its value really is in perhaps re-stratifying risk in a person that might not necessarily be a case for a statin on the information we have at the moment.
You know, occasionally you might get a patient who comes from a private clinic or a clinic overseas, and they have their printout of their results, and there's a lipoprotein A or it's one of those tests where they're jabbing at the page saying, do something about this, and you're trying to catch up with it. But that's useful. So there is an independent risk factor there. So at the bare minimum, it opens up the discussion around lifestyle modifications. If there's nothing to treat, as it were, in terms of blood pressure being normal, BMI being normal, and cholesterol being normal, if this is an elevated marker, then you can have that conversation.
Yeah, to advise that person, if somebody had gone to a private lab and got an Lp(a) that was raised, your latest European Society of Cardiology guidelines gives you a little graph that you can add their Lp(a) test result to their overall risk and see how that changes. So that's one thing you could do if you're interested. And the bottom line is what that person needs to do is have a healthy lifestyle, keep their blood pressure normal, keep their LDL to normal levels. And so the overall management is very similar to what we would already do for people with raised risk of cardiovascular disease.
Okay, thanks for that, Eamonn. And David, I suppose what we're talking about there is oftentimes a younger cohort of patients, and another obvious category in that younger cohort would be women of reproductive age. And you wanted to sound a note of caution around women who would like to conceive.
That's right. Increasingly, we are picking up cases of familial dyslipidemia, and these patients will be established on perhaps a statin plus ezetimibe. None of the lipid-lowering agents are safe in pregnancy or breastfeeding. So I think if you had a woman with familial dyslipidemia on a lipid-lowering agent, I think it would be very important and prudent to flag this up to them that it's not safe in pregnancy, that a pregnancy would be planned, that you would allow a 3-month period for the lipid agent to wash out before you would abandon contraception, get through the pregnancy, and then restart the lipid-lowering agent as soon as possible after delivery. But I accept that many listeners might find this a daunting and challenging case, so I wouldn't see any problem either of enlisting the help of a lipid clinic or a cardiology colleague in the management of such a case.
But having said that, David, as you said, we did a separate podcast on familial hypercholesterolemia, as I said, and a really important one to remember, if possible, when commencing a woman of childbearing age on the statin. At that stage, like a number of other medications, that it is contraindicated. So I suppose forewarned is forearmed, isn't that it?
Correct, indeed. And again, it goes for women also on various antihypertensive agents as well, which are not recommended in pregnancy.
Okay, thanks for that. Eamonn, before we wrap up, I think you've got some of the numbers in front of you about actually the value of embarking on these strategies to our patients, and that might be a good place to end. Would you mind just going through some of the numbers?
Yeah, so I suppose at the end of the day, we're about preventing atherosclerotic disease, and LDL cholesterol is a very, very significant risk factor in the development of atherosclerotic plaques. People like sometimes to keep numbers needed to treat in their heads. So if you think of it, even on the kind of low-grade statins that were the first trials, like the 4S study, there was a numbers needed to treat of 15 to prevent another event in somebody who already had an event. So that's the secondary prevention value. And that's even less with the higher potency statins. And we're looking at, in terms of, we're often wondering about trying to convince somebody who is at risk of an event but hasn't had one yet. And sometimes it's a difficult job to persuade them to take a statin. But, the numbers needed to treat in primary prevention is in around 40 or less. And, so that's quite a significant benefit in terms of reducing the chances of something that could cause death or significant morbidity in the future. So I think there's no doubt about it that our current obsession with managing LDL and getting it to target comes with significant benefits.
Many thanks to Dr. Eamonn O'Shea and Dr. David McConaghy for speaking to me today. And don't forget to check the show notes for chapter markers, links to resources, and a full transcript of today's episode. If you have any comments, feedback, or indeed suggestions for a future episode, please let us know. You can drop us a line at podcast@icgp.ie. And that's it for today. Many thanks again for listening, and until next time, take care.